Hello, I'm Tina Cosby of WTLC AM 1310's Community Connection, and welcome to Real Talk, the status of minority health. We're going to be talking about the association between chronic disease and health disparities, especially in Black and Brown communities, and especially in the age of COVID-19. Health disparities have always existed for the minority communities, but the pandemic is shining a brighter light on that fact, and data has long shown that Black and Brown people have a higher risk for heart disease, stroke, cancer, asthma, influenza, pneumonia, and diabetes. In short, a higher risk for more serious disease, more serious sickness, and a higher risk for death. Health advocates point to a lack of information, income, healthy food deserts, and racism as the driving forces behind many of these disparities, actually a driving force behind all of the disparities. Generating awareness of these conditions is an important factor in moving health and wellness forward for these communities. Quite important. In order to facilitate this discussion, we have quite a distinguished panel on hand to help lead us through this important discussion. And as we bring them in, we will ask each of them to please introduce yourselves and let us know what you do. And after we get through all of the introductions of our esteemed panel, we'll get started with the questioning. So we can start up here with my screen where I can see Dr. Wright. We'll let you go first.
I am Curtis Wright. I am the CEO of Eskenazi Medical Group. We are the practice group affiliated with Eskenazi Hospital and Health and Hospital Corporation. We have about 250 providers for primary care, hospital medicine, advanced practice providers. And I am clinically a hospital medicine physician.
Hi, I'm Anita Gaylord, and I have 20 years of experience in tobacco control. I worked at the state of Indiana, the Tobacco Prevention and Cessation Commission, and spent all that time as the director of community programs, organizing nonprofit and community organizations to do advocacy for tobacco control across the state of Indiana.
And Shakata, Ms. Norwood.
Hello, my name is Shakata Norwood, and I am a community health worker supervisor with Eskenazi Health. We have a total of 10 community health workers going out in the community, trying to reach the social determinants of health and trying to make sure people get educated on the COVID vaccines.
And last but certainly not least, Mr. Del Monte Jefferson.
Hello there. I'm Del Monte Jefferson, the executive director of the Center for Black Health and Equity. This is a national organization that promotes public health programs that benefit communities and people of African descent. I'm also pleased to say that my board chair is Miss Anita Gaylord, who's also on this panel.
Let's get started. We've established this with a little brief intro, and we're going to jump right into it. But the first question, the Black and Brown communities fare worse than their white counterparts. We've established that, especially when it comes to health status. Why is that, and what is the status of health disparities? We touched on it just a little bit. Let's take a little bit deeper dive, if you will. And whoever wants to jump into that first, I will let you, and then we'll just go around.
You know, basically health equity is not now, nor has it ever been valued in this country for African Americans and other priority populations. And so we don't value it. And of course, that was even going back as far as the Freedmen's Bureau right after slavery, when they tried to create an organization or institution from the government standpoint to take care of those freed slaves. It lasted for a little while, but then it went away. And then just look at our fight to get the Affordable Care Act and Affordable Care and Insurance for, priority populations and others that are less fortunate. So health equity has just not really been valued, and that's taken a heavy toll on our healthcare systems, our economy, our educational systems, and our mental health.
Do you think that COVID has brought this to light in ways that it's never been brought to light before?
Absolutely. It's brought it to light, but I won't say in ways that it hasn't been brought to light before. I mean, just look at the struggles that we've had. Look at, one of the other topics we're talking about is tobacco control, right? We're talking about tobacco and go back as far as 2009, they passed the Tobacco Control Act, but yet they excluded menthol, which is a product that mostly African Americans smoke. So again, it wasn't our health, and our health care was not valued, back then. So there are other examples of it. Now, COVID did really lay everything out to bear, but there's been examples all along that our health equity is not valued.
Speaking of tobacco, why are minority communities such fertile targets, Anita?
As I thought about the topic, it crossed my mind that we've been talking about this, like Delmonte said, for years and years and years. And we know a lot of things about the tobacco industry, and we have known these things about the tobacco industry for a long time. Things like they target our communities. The marketing tactics for the tobacco industry in our communities, in Black and Brown communities, are completely different. And it's been documented. It's easy to see for the average person who's looking that the tobacco industry targets certain products and is very much in tune to what the Black and Brown community will respond to. I always say the tobacco industry knows more about us than we know about ourselves. And then the products that they promote, they know have a tendency to appeal to us. We know menthol. We've already mentioned that. We've been talking about menthol for what feels like forever, and still need to continue to talk about it. We're still have problems with cigars, with little cigars, cigarillos that I think were developed and flavored just for us and for our community. The e-cigarettes, the exposure to secondhand smoke. There are just all kinds of problems. And it's, I say that the tobacco industry spends a lot of time figuring out how to keep us addicted to tobacco products.
Yeah, and Anita, it appears as if they're starting younger and younger and younger, because campaigns as of late have targeted our young people, shamelessly targeted our children. I'm sorry, go ahead.
Yeah, I was gonna say we got rid of cartoons a long time ago, but that didn't get rid of the marketing to our kids. I mean, the industry knows they're replacement users, so you have to go after the kids because that becomes the lifelong tobacco user, and that's what they're looking for. So it for someone who, like me and Delmonte, who have been in this business for a long time, it is frustrating to still talk about the very same things that we've been talking about for what feels like 20 years. Why do we live in a country that allows the tobacco industry to do what it does year after year to our communities without passing laws that are logical laws that protect our communities from this deadly product? We know what it does. We know the impact that it has, and we know what to do to manage, or at least to help people never start to use tobacco products. So it's a tough issue, and it speaks to racism across the country when the tobacco industry can do this to our communities.
Yeah. So the legal restrictions that are in place are basically ineffective. Is that what you're saying? Because they're not allowed to advertise on TV. They have to put the warning on the package, but they have gotten around so much of that.
Yeah, they do what they know doesn't really work that well. We push for big time laws that we know will make a difference, like the smoke-free air laws, like getting rid of flavors, including menthol and all other flavors as well. Keeping them out of our communities, keeping them out of our schools, making them tell us what they use in these products. All kinds of laws could help eliminate, hopefully, if not completely eradicate tobacco use in the United States and in the world.
Yeah, Dr. Wright, you are on the end where habitual problems with tobacco long-term use, by the time it gets to the medical community, it's a double problem because of disparities, in terms of what has been allowed and financial and access to healthcare. So you're on the other end of that.
Absolutely. There's a target on, Black and Brown folks' back. And, as you mentioned, and I'm sure Shakata will be able to speak more eloquently than me, these social determinants of health restrict access to healthcare, whether it be finances, whether it be access to transport, whether you're homeless, access to food. People are making decisions whether to eat or, be able to go to the doctor. Structural racism, all those things impact, whether or not people are able to access care. And, in the medical community, we're at a stage where people are able to acknowledge that racism has existed within medicine. There was a period of time when I was training where, everyone was treated equal, and, we took a blind eye to those things. And, that blind eye, I think, was also a step back. I think that we need to acknowledge that these things happened, they continue to happen, and, actively combat them.
Shakata, let's talk about COVID and racism. I know this is a crazy way of looking at it, but has there been a silver lining, if you will, with the onslaught of COVID, in that it has shined such a huge light on the racism and the racial ethnic disparities in our healthcare system that we can fix going forward, or that we at least are made aware of going forward? Has that been the case?
Yes, it has. The numbers of deaths that we've had with people who are losing their lives over COVID, it has been a major eye opener. So when we're trying to educate patients and educate our people on how and why it's important for us to get this done, because a lot of them they're blindsided by it. Oh, it's not going to happen to me, or oh, I've had COVID, I don't need the vaccine. But we're explaining that the vaccine is keeping you out the hospital and it's keeping you alive. Look at the ones that we have lost, because the majority of the people that have really lost their lives is a lot of African Americans.
So kind of based on that, why were we the last ones to the party in terms of accepting the fact that the pandemic was real, accepting that vaccines help, accepting that we better get going because we are the ones most disproportionately impacted? You were right there on the front line. Tell me and tell us why did that happen like that?
Because, excuse what I'm going to say, a lot of us African Americans, we feel like it's our way or no way. A lot of us didn't want to listen until it hit home. Now that it hit home, now we're asking questions. We're asking the questions that we need to ask, and it's not necessarily it's even with the tobacco. Like, I seen my daddy smoking, so I think that's the right thing to do. So this is how we're being educated. Like, it's like following suit. So we have to figure out how to break this chain and get everybody aboard. Not just because, oh, it hit home. No, let's tell everybody.
The other part of it is the misinformation.
The misinformation
and the disinformation campaign that was going on, that we all had to battle day in and day out. The deliberate, targeted, intentional disinformation campaign.
I mean, I heard that Black people couldn't get COVID. And so there's a lot of folks, well, why do I need to worry about this? That's a white person's disease. And that was the furthest thing from the truth. And so it's just misinformation and disinformation out there. Now, of course, misinformation, that piece where we just, we're misinformed, there's a little bit of truth in it, and it's taken and it's twisted around. But then there's the disinformation, the deliberate and intentional spreading of lies, of fake news, of rumors. And so
it's the social media.
And social media.
People are living off of what they see on the social media. Because if you remember, when they first started talking about the vaccine, they were talking about it was a chip. They were giving us this information. Oh, it's a chip, don't do it. Mm-hmm. Or it's gonna make you extremely sick. But if you think about it, if we take any vaccine, there's a side effect from it. Mm-hmm. But that does not mean we shouldn't take it.
How many times did you hear, we don't know what's in there, I'm not taking that? I heard it daily. What was so different about this one?
I think it was just because somebody said that we had to do it.
Exactly. Yeah. Good point. Very good point. So you were saying, and I asked you a question earlier, that in a way it has been a positive in the sense that we can start to get some things going now in the right direction. Expand on that a little bit more for us, please.
So when I say the positive, when I talk about the positive, we're able to, so the things that a lot of our communities are not able to see or hear, we're able to get CHWs out doing home visits, educating patients on what's important. And it all starts with the social determinants of health, figuring out what's going on with them. So, if I tell you that I have a food insecurity, if I have a food insecurity, guess what? There's something else going on. So it's the CHWs that's going out and figuring out what else it is. And then we're educating them. Did you know where you can go get this vaccine done? Did you know that you can walk in and get a free testing kit? Did you know that you did not need an appointment to get this vaccine? Did you know that if you get COVID, it attacks your immune system? It starts immediately. So it's not, you look at it like, oh, I just have a cold. No, it's not a cold. Let's figure out what it is. We have people that are going out to the homes and educating our patients.
How's that going?
We've been doing this for about a month now. We have other programs with the diabetes program, but we just started the COVID, and we have, as of today, before I got on, we have a total of 105 patients that we have touched.
Dr. Wright, how far behind are we as a community, Black and brown? I'll say communities. How far behind are we?
We're pretty far behind. I think, some startling numbers, particularly related to COVID, is that the life expectancy for Black and brown people has dropped 3 years compared to a white person, which is only 1 year. So 3 times more likely to die after COVID. So that's how disproportionately we were impacted. Whether it's diabetes or high blood pressure, or at this point, if we think that COVID is endemic, it's preventive medicine. And as Del Monte said, is that preventive medicine in the US has not been a priority for anybody, and particularly not Black or brown people. So we're fairly far behind. If you look at most major disease states, whether it's diabetes, heart disease, cancer, you're more likely to have death, side effects, morbidity, you name it, if you're Black or brown.
Well, you know what? And another thing that adds to that, being far behind, is the continuous exposure. Over the 2 years of this pandemic, Black and brown people have been continually exposed to it. And what I mean by that is, while most of America was able to sit at home and stay at home and work from the confines of their home and not have to go outside and be exposed, somebody had to man the grocery stores. And most often than not, those folks were Black and brown people that had to man the grocery stores. If they had hotels, somebody had to man cleaning those rooms, mostly Black and brown people. If they had restaurants that were open during that time, somebody had to man the kitchen, mostly Black and brown people. And so there's this, not only are we behind, but we have been continuously exposed, while others have been able to sit at home, work from home in the confines of their home. And so that also puts us way behind.
So how do we catch up?
The solution to this, of course, is twofold. First, there's got to be government support. There has got to be government support. We're seeing the numbers go down a little and they start taking away rental assistance. The numbers go down a little and they start opening up all the restaurants. Numbers go down just a little and they start changing all these policies that make us to be exposed once again. We got to be vigilant. This thing is not over. The numbers are down, but this thing is not over. And so we have to be vigilant. And that's going to come with government support. So we're going to need that. We can't go kicking people out of houses. We can't go making folks have to go back to work. We know that that's going to happen at some point in time, but we can't go forcing this on folks. And so we're going to need that. But then we're going to need the community health workers, like Shakata was saying. We're going to need folks going out with truthful information, trying to help them get screened, help them get their shots, bring the shots to them. You don't always have to go out to get the shot. Bring the shots into the communities to where they don't have to worry about transportation issues. Bring the shots into the communities, and then have those resources, broadband resources. We should have had that. in our communities, but we don't have that all over the place. We definitely don't have it in our rural areas, but we needed to have broadband access so our kids can stay at home if they need to and learn from home. And so we've got to make some changes at the government end. There needs to be these changes at the community end as well.
Speaking of changes at the community end, Dr. Wright, is, for lack of a better phrase, does it feel to you sometimes like we as minority communities have become tone deaf to the messages of heart disease, stroke, cancer, diabetes, asthma, pneumonia, to the point where, it's almost like a shoulder shrug so much, anymore. And maybe it has to be like COVID. Maybe it has to hit you before you take it seriously. But how can we better drive home the message of the seriousness of these particular diseases that impact us so disproportionately?
Yeah, it's just like anything else. It's, who delivers the message and the content of the message. I think that to date, as was already said, this has not been a priority. If you look at healthcare in the U.S., it's all about sick care. We wait until you're sick. We value surgeries. We value, $1 million medications. We do not value primary care. We do not value our social workers. We do not value the things that actually prevent people from getting sick. We would have billions of dollars, if we, prevented illness, and, you could choose one of those illnesses and have billions of dollars. So I think, making it a priority, changing the message to actually meet the needs of those that we're actually trying to, get better.
Anita, do you have any facts or figures regarding the rate of lung cancer in the state of Indiana?
Yeah, and I don't have any specific figures. I mean, the figures are available. I don't have them in front of me. What I do know is that even when tobacco use in the country goes down, there's still a significant gap between, say, tobacco use and minority and underserved community tobacco use. Even though, generally speaking, let's say smoking has come down. There was just a memo recently going out from CDC that says, in general, the smoking rates have been decreased, but not. But the disparity gaps are still there. There's still an unacceptable gap with tobacco use. So it kind of gets at what I think Dr. Wright is saying, is that we have talked about prevention for a long time, especially as it comes to tobacco use, and we've talked about ways to quit. We call it cessation, helping people to quit using tobacco. And the state of Indiana has a quit line. We know it's underutilized by our Black and Brown community. So we have to continue just to talk about ways to eliminate tobacco use. And I think some of that comes with a strong youth program so that young people begin to understand how the tobacco industry targets them. So some of that will help. And, so we can get a little bit more on the preventive side of it, but it's hard work. We've been doing this and talking about this for a long, long time. And we still have difficulty getting the message across or staying ahead of the tobacco industry. They're always ahead of us. They have these e-cigarettes came out about the time that regular cigarette use was starting to really plummet with young people. I mean, literally plummet. So, and then all of a sudden this other product comes out, and while the combustible product use went down, the e-cigarette use skyrocketed. And I mean, really skyrocketed, even among our minority youth. So it is very difficult to stay ahead of the tobacco industry. And I think, Del Monte talks about government interference. There are big time laws, national laws, state laws and national laws that we can pass to help mitigate some of this. And we just haven't been able to get the country to get on board with it. It's very difficult to fight the tobacco industry.
Is Indiana more egregious than any other states? I mean, are we in any particular category? Are we in the middle of the pack?
Yeah, the Midwest, there's a section of the country that's kind of the Midwest, and Indiana is in this group. We call it Tobacco Nation, which it's not a compliment. It's the states that have the highest smoking rates and the the worst laws are laws that don't protect people. And we're working on that. And the center is working very hard in what we call Tobacco Nation. So Indiana is, I don't know where we are exactly right now, but we've always been, I never know how to say it. We've always been in the top 10 or the bottom 10 with the highest smoking rates.
Right. Yeah.
So,
In a place that you don't want to be. It's a distinction you don't want to have. That's been my understanding. And the rate of lung cancer in the state of Indiana. And Dr. Wright, you could probably address that. But I want to go to Mr. Jefferson, because you had your hand up. So
yeah. Anita, is Indiana a preemptive state?
Not on smoke-free policy, but on youth access and retail policy, we're preempted. Yes.
Yeah. See,
so we can pass. We could pass a comprehensive statewide law that would eliminate tobacco use indoors today. Well, not today because they're not in session, I don't think, but we could pass.
No, they're out.
We have not passed that. So we've had to pass it community by community, which really is, town, city, municipality by town, city, municipality, sometimes a county. So we can still pass that law, but we don't have a strong statewide law. Right. And we are preempted when it comes to the retail stores, which happened 20 years ago. And when it happened, frankly, we didn't know exactly what it meant. But today we do understand that if we could pass some laws that would prevent some of the presentation of tobacco products, say, in the convenience store right by the school, then we could make a difference. But we can't do any of that at the local level.
So the tobacco industry, when you talk about how far ahead they are, of us, they work with legislators. They put things in place. They lobby. They get preemptive laws in, and 20 years down the road, you still can't do anything about those laws because of preemption. So when you talk about just being behind the 8 ball and having to play catch up, we're catching up for decades of the industry's lobbying efforts.
Yeah, indeed. Dr. Wright, are you familiar, and if you know, fine, rate of lung cancer in the state of Indiana?
I do not know. What I do know, though, is that if you're Black or brown, you are less likely to undergo lung cancer screening, even though it might be recommended, and you're more likely to be found with terminal disease at the time of diagnosis.
I take it from a couple of these conversations that we got to get people to vote the right folks in there to get the right laws made and put out there, at least for Black and brown communities.
Well, that is absolutely the case in terms of building capacity at the local level. Another reason you don't have these adequate policies, like if you pass a policy, right, and the policy is driven by lobbyists, whether they're heart, lung cancer, or any of those voluntary groups, and they get a policy passed. Well, that's fine and dandy. But if the community isn't supporting it and isn't backing it, how enforceable is it going to be? How effective is it going to be? And so until you start building that capacity locally and having the community saying, hey, we don't want this in our community, we don't want this in our neighborhood, lobbying for it, and then going to their legislators and say, hey, legislator, we don't want this, so what do we do about it? There's got to be that outcry. And without the outcry, again, the industry is going to rule. Preemption is going to rule. These other policies are going to rule.
So, Dr. Wright, do state policies, healthcare cost, prescription drug costs, make your job a lot more difficult?
Absolutely. I mean, I am a firm believer that, we need healthcare reform, in general. I mean, we have a system where you're less likely to get healthcare, period, if you don't have health insurance. And, that system, doesn't need to be that way. I think that, as I already mentioned, we value specialty care. We cannot get doctors to become primary care doctors because they're not compensated as well as a orthopedic surgeon or a heart surgeon. So we have everything flipped backwards. There is little penalty as a patient to go to an emergency room versus a primary care doctor. All these things incentivize sick care. I think that is a major problem for all Americans. And it's definitely a problem for Black and brown folks that have decreased access and all these social determinants of health issues that are, making it, impossible for them to get the care that they need.
I like the way you said that, incentivize sick care, because that's a very good way of saying it. So Dr. Wright, how would you, if you had it, how would you start to fix it, or how would you fix it? What are some of the things that you feel could be taken care of right away?
Well, it is a heavy lift. I agree with what was said. Make it a priority. There needs to be governmental interest in healthcare. I think that, it's been on the table for years about value-based care, so that, your healthcare providers do not get paid as well unless they deliver good care to their patients. And that's not the way that it is today. Today, it's fee for service. You get something done, for the most part, I'm going to get paid no matter how you do. And it shouldn't be that way. We should get compensated, based on, outcomes. So that is, a step in the right direction to get governmental oversight. But I think that we do need, to work on equal access to care. We need to make sure that there's, equity amongst, all. And, there's a lot of ways to do that. But, it starts with preventive health, and it starts to, again, incentivize the things that drive people in the right direction. And that's for providers, that's for pharmaceutical companies, and that's certainly true for patients as well.
Shakata, we're talking about messaging, and that's a big part of what you do. How do you, or how have you navigated COVID when different variants have come to the attention of the healthcare profession?
We keep making sure we get the education that we need so we can keep letting our patients know. So just because I come out to your house today and we talk about it, when I come back in 10 days, we're going to talk about it again. We can talk about everything else with the social determinants of health, but this vaccine and how important it is. So I think the most part is for us to make sure we stay educated and make sure we stay updated with what's going on and what's coming out.
Delmonte, you are in the culture changing business, so to speak. What do you advise now? I mean, and what have you seen up to this point? Are you encouraged by what you've seen up to this point?
Well, that's a good question. Thank you for that. In terms of, let me answer that last part first. Am I encouraged? There are things that are out there. There are resources out there. But the discouraging part is the fact that we need all these resources out there. One of the things that we have out there as a resource is this website. It's called TruthCheck, truthcheck.org. And what we're trying to get folks to be able to do is to really learn how to decipher inaccurate material and information in social media channels on your own. So we're not, going out dispelling information. We're not saying this is wrong, this is right. We're saying learn how to decipher for yourself. Now, the discouraging thing, I mean, I'm glad we've got that resource out there to teach people how to look at social media and say this is wrong or that's wrong. But it's crazy that we have to do that. It's great because we've got, again, as we talked about earlier, there are still African-American people spreading misinformation, spreading things that's not true that they got from the dark corners of the web. And, and this whole social media thing that we've got now, where the most important thing in the world, the most important thing is a likes. I've got a daughter and she's talking to me about, hey, if I did this, I can get a lot of likes. And I have to tell her, so what? Who cares if people are liking stuff? But that's where we are right now. Yeah. And so, having the fact that we've got to combat social media and this whole need for likes, that's very discouraging.
Yeah, it is. Likes a lot of times, they elevate you, obviously, socially, but likes also translate, as we all know, into dollars. So, you know what? Here, I'm sorry. Somebody else wanted to weigh in.
This is Anita. I want to just say something that's kind of on my mind, and that is that, and it goes, I think, along with what we've been talking about.
Okay.
And that is trying to get the right information to our community, to our state. And I have always pushed for what I called a population-based intervention, which means that we have to spend the money where we can reach a lot of people through a medium with the right information. And to me, that's a public education media campaign, which causes us to have to make a huge investment. So we're, I mean, I probably shouldn't say this, but like the Geico commercials, and that's a $6 billion investment. But people get their information from mediums now. And if there was a way for us to change their attitude and their beliefs about tobacco, about COVID, about prevention, about access to care, and we use the mediums that are available to us because that's where they're getting their information. That's what we've been talking about. If we would make an investment in that, I think fairly quickly, but at least over time, we would get a change in our attitudes and beliefs. That's how you change what people think, what people know, the information they get. So it's huge. It's hard to do. It's not easy to do. It's hard to get the kind of investment that we have to make. It's hard to get government support for that kind of a campaign, but that's what I have preached for a long time. It's like a multimedia educational campaign because we know they work. We know in tobacco control, at least, that they work. And I think they'll work on some of these other issues as well.
But what she's talking about is a targeted money for a targeted campaign. It sounds like what you're saying, Anita, it depends on who's delivering the message as whether or not people listen.
Well, who's delivering it? What the message is?
What the message
there's
is, yeah.
research, and we know how to do that, or we can learn how to do that. We just haven't been able to do it.
I think that would be a fantastic idea.
Yeah.
If there's money to do it, and you're right, it
takes a lot.
Yeah, as Dr. Wright said, it's a heavy lift. But one of the other things is, we're getting ready to wind down just a little bit here, and I wanted to get a couple more thoughts in. But we talk about one of the frustrations that I often hear people complain about is that I didn't know that X, Y, and Z existed, or I didn't know that I could call this or call this place, or that I could have this or have that. Access to the resources that exist. Dr. Wright, Shakata, Anita, any of you have any ideas on how we can better bridge the disconnect that seems to exist in our community, or the disconnect that the community complains about, and access to what is available?
I think people, African American and brown people, have gotten used to, like, we have Cubs grocery store this week, and next week we don't have it.
Mm-hmm.
They have gotten used to that. So I think it's more of figuring out a way. It's almost like having a family reunion. What brings everybody together? What brings, when you're going to have a family reunion, what's the first thing everybody comes for is food.
Yeah, I was going to say food.
If you're saying, okay, the social media, and we all know from TikTok to Facebook to Snapchat, we all know that they give bad information. So what other way to get people more involved is let's have a community outreach. Let's bring the people back out. Let's figure out how we can get them back out in the community so we can tell them about it, so we can educate them. So if you got somebody standing right in front of you, giving you the information and showing you how important it is, what better way to do that than to be in person?
So you're saying you have to personally bridge the access gap.
Well, yeah, and another way, because it fits right in line with this whole personal atmosphere, is about 7 years ago, we wanted to get out a cohesive message about how menthol products were impacting our communities. And so we had a group of pastors. We had a group of pastors that were together, and we talked to them, and we asked them, well, how can we get this message out? Pretty much the same question you're saying. And what they said was, well, we can all share the same message, the same information from the pulpit on the same day, on the same day. And so that started what we call now No Menthol Sunday. That was 7 years ago, and it goes on right now. Every year on the third Sunday in May, pastors from across the country are talking from the pulpit about mentholated tobacco products. And so that's another medium that we have. And that's one of those like personal mediums. And even last year, I think it was that we had to do it virtually, of course, because of COVID. But that's an opportunity. We do have our church. We have our churches, and we can utilize our churches to put these message out to our populations that way as well.
Dr. Wright, your ideas or your thoughts on better access, bridging.
So
access.
I think the message needs to be tailored for the audience. And, I appreciate what was said about the tobacco cessation. I do think that would work if we had the funds.
Yeah.
It probably wouldn't work for diabetes, for instance, because you have a different, population that, accesses information differently. But we do a terrible job at this. I mean, my source of information for COVID, for example, would be the CDC website. And if you get your average person to go to the CD website, they are not going to find the information that they need. They're going to scroll through. They're not going to have any idea what they're looking at. And it would be a miracle if they actually found it. So the people that are working against us are spreading their disinformation through social media. We should be doing the same thing with real information. Your average Joe doesn't want to read a paragraph. They want to read a tweet. They want to have access to something that is, meaningful to them. So I agree we have to get people to the right information, but that information, when they get there, needs to be in a format that they're going to actually consume. And it's not what we do today.
Yeah. And Dr. Wright, the sad, unfortunate reality with COVID has been the merging of medicine and politics. To where you're making a political statement if you wear a mask, which is just absolutely insane. How do we get past that? How do we get beyond that? Because I don't think that's ever happened in our history, where a particular disease or a pandemic, epidemic, what have you, has been so politicized.
Yeah, I mean, it's a hard thing, but I think at the end of the day, for most of these issues, we have to vote some of these people out. I think, it happens because we allow it. I think that, if we get the right people in office, they'll do the right things. And, we have to hold them accountable for killing people. I think that's the saddest part of this. Some of these behaviors, the disinformation is leading to people dying, and that seems to be okay.
Before we close, I'll ask each of you to share, any closing thoughts or final thoughts that you have in terms of where we are, where we're going, or where you hope for us to eventually be regarding closing these disparities in our healthcare system, in our Black and Brown and minority communities. And we will start with Ms. Shakata Norwood. You have any closing thoughts?
I'm a firm believer in communication.
Mm-hmm.
We have to communicate with each other. If we have no communication, we're losing. And to get people back connected, because it starts with the front line all the way back to the end. Getting people connected, finding out where they're at, and meeting them where they're at.
Dr. Wright.
Well, a couple of things on the COVID front. As was said, we are not out of the woods yet. I think people need to be aware. And I want to say that, if you were vaccinated and not boosted, you are not vaccinated. You need to get boosted. It is very likely that we will have another COVID variant, and it is also very likely that our lax of behaviors is going to lead to another surge. So I want to make sure that everyone goes out and get boosted. The other thing that I'll say is, be a advocate for yourself and for others. I think that we've spoken about the importance of voting in the right people into office, because they do have, a lot of control of what happens to, all of us. Seek out the right information, and then also seek out a healthcare provider. We talked about preventive health as being important. We're not always right. We have not done this the way that it should have been done in the past, but we ask for your grace, and we'd like to, work with patients, community members, you name it, to prevent, a future pandemic, to prevent morbidity, to prevent mortality, to allow people to live, healthy lives.
Anita?
Our communities have got to participate in the political process. And I know that's much easier said than done. And it's, not always easy for someone that, for instance, who works and, the meetings are at times when you can't get there. But we have to, in any way we can, participate in the political process and get the right people in office. Because when it comes to tobacco control, a lot of what matters happens with passing laws. And so in order for us to, I think, make a big, huge step in prevention, in cessation, helping people to quit, in keeping young people from ever starting to use tobacco, that's, my area, it has to do with passing the laws and understanding what it is that we need to do. And then we also have to take personal responsibility, kind of like Dr. Wright said, pay attention to what's going on in your community. Pay attention to the advertising. Look at what the tobacco industry is doing. If you really want to get active, be an advocate, speak up, be supportive, seek out the coalitions that exist in your community that are working on this, and see if we can't, in the next few years, make a big difference. We know what to do in tobacco control. We just have to get that work done. So I encourage anyone who has any, just a slight bit of interest in advocacy when it comes to tobacco control to reach out and figure out what it is you can do in your community.
Wonderful. Thank you. And Mr. Jefferson.
If African Americans, and we know that African Americans are the ones that are most impacted, most disproportionately impacted by COVID, by tobacco, by other health disparities, then African Americans likewise have to be actively involved in reversing those trends. We cannot depend just on the government. Does the government have a responsibility and a role to play? Absolutely. But how are they going to get off their hands and do that? Because we're going to insist, we're going to actually demand that the government gets up and they do something, that our legislators get up and they do something. So that, as Anita said, is participating in the political process. Because Dr. Daniel Dawes, he's over at the Cessation Health Leadership Institute, has this wonderful book out talking about the political determinants of health. And if you haven't read it, you need to read it, because it really looks at the fact that it's not just the social determinants that we can see. We can see transportation, we can see housing needs, employment needs, we can see all of that, but it's all the politics about what's making those things happening in the background that we need to be aware of as well, and how we can enact change on those things that are happening in the background before you even get to the fact that a bus route is not taking you to a grocery store or going to a hospital. Well, somebody is back there designing those bus routes, and those are the political determinants of health. And we've got to be in tune to them, and we've got to be engaged in that process.
And very quickly, before we wrap up, on a scale of 1 to 10, 10 being the best, where would you place the status of minority health in the state of Indiana, city of Indianapolis, Marion County, all combined? The status of minority health, how would you rate it? Is it 1 to 10? Anita.
I don't really know. Let's just say 5, somewhere in the middle.
Dr. Wright?
I was going to say a 4.
A 4?
Yeah, I think that we're below average. So I think that, and the 4 is probably better than the 3 or even less that we were, like even 5 or 6 years ago. So I think we're making some progress, but we're definitely not where we need to be.
Ms. Norwood, on a scale of 1 to 10.
I'm going to go with Dr. Wright, because we are, I'm going to say about a 4.
About a 4. Okay. And Mr. Jefferson?
Well, although I don't live in Indiana, I would have to say a 3. And now the reason I'm going to say 3 is because Indiana is, as Anita said, a part of Tobacco Nation. And Tobacco Nation are those states that are disproportionately impacted by tobacco use for African Americans. And so for that reason alone.
Delmonte Jefferson, Shakata Norwood, Anita Gaylord, and Dr. Curtis Wright, thank you all so much for being with us. I think we can take away from here that disparities continue to exist. We all need to be more politically active. And most of all, we all need to be personally involved and to become advocates for our own health care and just take personal responsibility for that and more in the coming days, weeks, months, and years. I'm Tina Cosby.